Welcome to the Doctor's Corner with Dr. Kline and Janelle Elgaway. And now, Dr. Kline and Janelle Elgaway.
Good evening and welcome to the Doctor's Corner on Ka360 Network. I'm your host, Janelle Elgaway, and we are here with co-host Dr. Kline. Welcome, Dr. Kline. Tonight's topic is on ketone management of types 1 and 2 diabetes, much better than blood sugars. Also, there are two ways to listen into tonight's program: through our website, www.knation.com, or YouTube channel, The Doctor's Corner. Dr. Kline loves to hear from you and answer all your questions from our mailbag. If you have future mailbag questions, please email them to Janelle, Jonelle, Elgaway, Elgaway, at Ka360.com. If anyone would like to call in with questions for this evening, you could do so at 415-915-2291. So before we get into tonight's program, Dr. Kline, is there anything newsworthy that has occurred in the last week that you would like to share with us? Dr. Kline? Hello, hello.
Oops, the old mute button.
Okay.
Yes, not used to being on the radio. I'm used to spending my time down at the donut shop. But anyway, yes, there is a piece of news. Well, there's been in the news recently that the price of insulin has now reached the point that people can't afford it. This is called health care profiteering. If something is in demand, you just raise the price. It's kind of like street drugs. You know, we have some similarities here. However, manufacturing normally, with an increased demand, drops the price because you drop your unit price. So in other words, if a whole bunch of people want an 18-foot extension cord and the demand goes up, then the price drops because the manufacturer can make the 18-foot extension cord more cheaply. So that isn't the way it works in medicine. With demand, up goes the price. It's getting to be absurd as more and more companies making insulin are cashing in. So one of the things that people can do is to make sure that you need insulin, number one, and number two, you are trying to get the most efficient. Now, the American Diabetes Association can help you with that, but you have to be careful. You need to check their list of donors first. And many of their donors make insulin. So you got to be a little bit careful. The best way is to check with your pharmacist. You know, what is the cheapest per unit insulin that I can get? If you have type 1 diabetes, you got to have it because your body doesn't make insulin, so you have to replace it. However, in type 2 diabetes, insulin is being prescribed based on your blood sugar. And that's what we wanted to talk about tonight. A blood sugar of 350 can mean quite a few different things in different people. If you line up 10 people and they all have blood sugars of 350, one may be getting ready to drop the blood sugar. The other one may be getting to raise it. The other one may be sick. And the other one may be just fine, but he had a little cake. So with this variability in the blood sugar, we probably shouldn't use it to make decisions, but we do. Decisions are made solely on the blood sugar. When I was in medical school, I'll never forget the guy standing there, and he said, you know what? Blood sugar is the most variable commodity or test in your body because it's influenced by practically everything. Drugs, hormones, what you've just eaten, stress, what kind of food, blah, blah, blah. So basically the blood sugar is an inaccurate measure of what's going on in your body. It would be kind of like trying to predict the weather by going outside and measuring the temperature. There's a rough correlation. Today it was 33, so I'm thinking, well, there's a high pressure front, and so we're probably going to have nice weather. Probably. That's a very inaccurate measure of weather, but it's sort of correlated. So people have been kind of sucked into this. The blood sugar really reflects exactly what's going on. It's not uncommon if somebody calls the doctor and says, "Doctor, my blood sugars have been running about 250 and now it's 300. That the doctor assumes a person needs more insulin. And that's not true because of all the variability. So how can you determine what kind of test to use in order to make these important decisions? For example, starting insulin in a type 2 or adult onset diabetic. When do you start it? Guess what the criteria is? The blood sugar. A blood sugar. Right? So we have this inaccurate, bounces around variable, and we're going to make a decision about starting to use insulin based on that? Type 2 or adult set-on diabetes used to be called non-insulin diabetes. But the drug companies got together with some physicians and various clinics at major hospitals and with the American Diabetic Association, and they decided they would go off and have a conference and they would decide what a normal blood sugar is. And they decided the normal blood sugar should be 140 or 125. They just made it up. Now, this is surprising. There have been no large studies to determine what a normal blood sugar is for various age groups. It's considered that a blood sugar over 200 is very scary, and actually, it's not. I found one little study that checked older folks, and guess what? The normal blood sugar was normal up to 260. Oops. Now, wait a minute. We've been making these decisions, and now we got a blood sugar of 255 and somebody who's 70. Oh, you need insulin. Wait a minute. That's a normal blood sugar for that person.
Well, let me ask, is this would it get to that point, or is this where it would stay at that level?
Well, that's the problem. Blood sugars tend to get higher as you get older, and they're not taking that into account.
Right.
And what kind of blood sugar are you talking about? One that you measured at 3 o'clock in the afternoon? Two that you measured? Frequently, people stay hunched over their little machines called glucometers, and you put a little strip in them, and it tells you what your blood sugar is. And the price of these strips is going up too. So everybody's jumping in on the let's check these blood sugars all the time, because as soon as one gets up, we got to start more drugs. That's not true. So is there a test that you can tell exactly what's going on in your body without relying on the outdoor temperature? Yeah, there is. It's called ketones. Now, what ketones are is when the cell is starving. Okay, you're in starvation mode inside your cell. It goes and it starts taking fats and tries to make energy out of fats, which you can do in an emergency situation. But it produces byproducts that leak out into the bloodstream called ketone bodies. One of them is acetone, which is what you take off fingernail polish with. The other one is acetylsalicylic acid, which is done in small amounts. But the most important one is the main ketone. And the main ketone is called butyrate. Just to learn some new words, butyrate. So, for example, when you check the ketones in your urine, it's not the more accurate butyrate. It's the less accurate acetoacetate. So when you check your urine for ketones, that gives you some information, but it's not as accurate. The butyrate in your serum, hydroxybutyrate, is extremely accurate. 10 times more accurate than a blood sugar because it's telling you you've got intracellular hypoglycemia. You've got intracellular starvation. And the minute that happens, you start to crank out ketones. So whenever you see ketones in your bloodstream, something is wrong. Now, it can either be your blood sugar is too low and you have your little cells starving, or it could be you don't have enough insulin driving the glucose into the cells. The insulin is kind of like the bellhop at the hotel, carries your bags into the room. The bags are not going to transmit themselves into the room. So in the presence of glucose, cells do not just absorb the glucose. It has to go in with a bellhop. And that bellhop is insulin. Insulin drags and allows the glucose to go into the cell. So we're all sitting around fairly happy. We've just eaten because our insulin is going up and down and is driving the glucose into the cells. So how do we know that all that is doing the right kind of job? If you don't see the ketones, then everything is okay. In other words, you're not having the emergency furnace turn on. You're not having the emergency use of fats for energy to keep you alive. So when you don't have positive ketones, you're doing just fine. Now, it's the stress of the starvation inside the cells that cause cells to die. And when the cells die, guess what? That's what feeds into the complications of diabetes, which is more accurately termed the facets of diabetes. It's really not a complication of diabetes. It's part of the disease. I mean, we could say people that have lupus, for example, or rheumatoid arthritis, that they have joint swelling. Well, that's part of the disease. So all the bad things that you hear about from the American Diabetic Association, which I personally think is a way to raise money, and scaring people, you've got to watch that blood sugar. Actually, what they should be saying is, you need to watch your serum ketones, the hydroxybutyrate, because that's what's telling you whether or not your cells are happy. And if they're happy, you don't need to do anything. You don't need to start insulin. You don't need to raise your insulin. You don't need to run out and buy SL2, blah, blah, blah. There's now 10 groups of medicines to keep your blood sugar happy. But we already know it doesn't matter. The blood sugar is not an accurate reflection.
Let me ask, if somebody has too much insulin or takes too much insulin, what will happen to the body?
Okay, if you take too much insulin, your blood sugar drops, the cells in your body starve because it's driven your blood sugar down too low, and it starts making ketones. The alarm goes off. So too much insulin, alarm goes off. So you have a way to monitor by using serum ketones whether or not you're taking too much insulin. Because if you start seeing ketones, and then you can check a blood sugar. If you got low blood sugars and ketones, you're in deep doo-doo. You've taken too much insulin, and it is causing the death of cells. This is one thing you do not want, because this is what contributes to the we'll call them side effects of diabetes. If you look carefully at the eye and the kidney and the blood vessels in people with diabetes, what you see is death of cells and death of little parts of cells called pericytes. We'll talk about that some other day. But the scientists can look under the microscope and see the damage from hypoxia, which is low oxygen levels, and from hypoglycemia. It causes these cells to die. So in the back of your eye where you have a retina and it's not getting enough glucose, it starts to die, and then you get the complications in eye disease. So the key is not managing the blood sugar. The key is watching your ketones. So go ahead.
Levitt from YouTube wants to know, why don't doctors use the ketone test versus the blood sugar levels? And she also wants to know, do they have home strips to test for ketones?
Good question. At Children's Hospital in Boston, which I was associated with, the diabetes department there for children do use ketones, serum ketones, as a way to manage. So there's a good example. This is type 1 diabetes. These are tough cases. They're doing it. How come other people aren't doing it? I don't know. That's why I'm on the radio. I'm trying to bring not new information, but I'm trying to bring a new use for the information we've always had. Jocelyn, the famous diabetes doctor in Boston, used ketones in the urine, even though it's not quite as accurate. He used that because that told him that something was going on. If you've got ketones in your urine or ketones in your blood, something is wrong. It's never normal. So that's a great test. Because the flip side is if you put a stick in the urine and it's negative for ketones, you're doing fine. So is there a test for serum ketones? Yep. The Abbott Precision Glucometer, which is what you normally use to measure your blood sugar, is also set up to measure serum ketone, and it's mainly the hydroxybutyrate, the more precise one of the ketone bodies. And they used to be $5 a strip. I mean, that's awful. So just right before the show, I looked it up on Amazon, and lo and behold, they're $1. That's a big, big difference. So what a person with diabetes means, I don't like calling people diabetics. People with diabetes, what they can do is they can, this is just theoretical, this will bring sweat to the brow of most diabetics and their doctors. What they can do is just once in a while check ketones. You just poke your finger like you do for the blood sugar. You stick in the different strip. You stick in the ketone strip instead of the glucose strip, and you just sit there and it gives you a number. When I used to see people at home and my patients, they would report to me their blood sugars all over the place, and they get these little notebooks they keep, and I look at them and I go, well, so let's poke your finger. So we poke their finger, and their serum ketones are normal. I don't care what their blood sugars are, Yeah. Now, if they're, oddly, what I found, a lot of people, adults on insulin, I take them off their insulin, and lo and behold, what happens to their blood sugar? It drops. What happens is if you take insulin and your body doesn't need it, it causes your blood sugar to rise. So somebody says, well, my God, I can't stop my insulin. I'm 65 years old. I started it when I was 50. I'm a type 2 diabetic. I'm an adult. What'll happen to me? Well, you start lowering your insulin and you check the serum ketone, right? If it's okay, you're okay. So it doesn't matter what your blood sugar does. If you're feeling bad, it's a good idea to check your blood sugar along with the serum ketone, especially because it may be low. So if your blood sugar is getting low and you're starting to see ketones, you're in trouble. You need to get food in you or glucose in you or stop taking your insulin or whatever. You must prevent the ketones in the bloodstream at all times, because that's a sign that your little furnaces are working just fine. It's a little monitor. It's a great monitor because my experience has been not only is it accurate, it's numerically accurate. In other words, the normal is up to 0.3, and every single person I check it on is always below 0.3. There's not a lot of variability like there is with blood sugars. I mean, blood sugars are just awful. They'll go from 220 to 300 in 10 minutes, but that's normal in your body. Blood sugar is always moving around, and you're adjusting your own body's insulin. You're going to be storing some. You're going to get fat. So, blah blah blah. But you just keep monitoring the serum ketones, and you're going to be okay. You can relax. So, even in type 1 diabetes, oh my God, don't go to the party and have cake, because your blood sugar will go up. And if your blood sugar will go up, then you're going to have kidney failure and go blind. Not true. There's no substantial evidence for that. But if you keep your ketones happy all the time, at least you're not killing cells. And if you kill cells, that's what really causes the complications, and that's what shows up under the microscope.
We have a caller from area code 520. What is your name and what's your question for Dr. Kline?
Hi, my name is Marcia, and what was did you ask what was my question?
Yes.
Okay, I just typed it into the contact. Can you hear me? I feel like I'm cutting out.
I can hear you.
Yep, we could hear you.
Okay, my question is, I have been seeing a pain management doctor for about a year and a half now, and I was, I guess I graduated from going to his office monthly for my prescriptions to going bi-monthly because he considers me a model patient. I've never had any troubles with him at all, but he also knows that I'll never ask for him to increase my medication because I just feel like that is a definite red flag. And the problem with that, though, is that I'll never ask for more, so I'll just sit here and suffer like I feel like I have been for the last few months. And I don't feel like I'm being adequately treated anymore like I had been. And I'm afraid to ask for anything more. And I was wondering, is there any way to go about doing that without throwing red flags and we're still okay? You know, we're all still okay. I'm not being reported to anybody, or is that right?
No. That's all a big myth. That's all a big myth. Nobody's going to come and get the doctor because he raises your medicine. That's a huge myth. The federal drug police are looking for criminals, and they're looking for doctors they think are criminals who prescribe a lot of medicine without doing very good examinations and cranking people through, seeing 300 people a day. They're not interested in your little pain clinic raising the dose on your medicine. So relax. So we need to start using a new word, under treatment. It is negligent to undertreat any disease. I mean, so you come to me with cancer and we start some chemotherapy, but I'm just going to give you half the dose. We just don't do that as doctors. And so this is the only time when you are purposely undertreated. So you need to start using the word undertreated and say, doctor, I really feel I'm undertreated because when I sit around, and now you just start describing things that have happened to you. Don't talk about pain. You say, doctor, with this discomfort that I'm in, I can't go to the store anymore. I can't play with my children. I can't make love. I can't, all the things during the day. I like to go out in my garden. I can't go out in my garden because I'm so uncomfortable. And, and thank you, doctor, for getting me to this point. We're probably about 60%. And frankly, doctor, I think I could do more if I was at a little higher. Never ask for an increase. You let the doctor figure it out. You just present the problem to be solved, which is my functioning is better on this dose. But especially if you've had previous episodes, but when I was on a little bit more, don't talk about milligrams. When I was on a little bit more, these are the things I could do. I talked to a woman the other day who has had her medicines improved. She says she went to the store for the first time in 6 months. I mean, that's kind of nice to report to the doctor. That really gives the doctor an idea of what's really going on with you. Never talk about chronic pain. Always give the name of your illness. My rheumatoid arthritis, my CRPS, my blah, blah is really giving me a fit, doctor. And I'm just so uncomfortable I can't sleep. Very important to bring up the fact that you can't sleep. And I feel like because I can't sleep, I've got all this sleep deprivation and I have a short fuse and I feel depressed and my husband wonders what's wrong with me. And, weave a little story in. Remember that these doctors only have a few minutes. So you got to practice ahead of time. Try not to put any extraneous stuff in there, just like you're a reporter, like you've just written a little short story, and see what you're trying to do is finesse them. But you don't have to be afraid of asking. And if you don't say anything, they just assume everything's fine. And well,
I do, when I'm there, that the situation, he'll ask me my number, my rate of pain, and then he'll ask me why is it different this time compared to last time, and then I'll explain him what's been going on, and it's been happening about the last 3 months this way, And the last 3 months, I lead with the same dose that I had 3 months previous. And I'm looking at this winter, and this winter is hurting it's so bad. It's been an extremely difficult winter for me, and we still have a few more months to go of this cold weather, and I'm just looking at life thinking, I don't know how I'm going to be able to make it through the winter,
Okay, well, you can talk about generally in your case that you seem to be worse in the cold weather. Now, people don't believe that, but it's definitely true. And you can say, over the past few months, my pain level has been slowly creeping up. And don't say why, or just, let him figure it out, or her. Let him figure it out. And I'm in a lot more discomfort, and then stress the functional losses. If you go into the doctor and tell them your pain is an 8 now, they're not going to do anything. You got to tell them something's happened to you, and you're spending more time in your Barco lounger. You're not going out. Those are the things that will help. But this is a very common problem. There's 6 million people like you, so hang in there and don't be afraid to ask. And thanks for calling.
Really appreciate your help.
Thanks, Marcia.
Bye-bye.
Ghana Boy on YouTube wants to know, how would you address a person with blood glucose over 260 consistently, but their ketone levels are normals and don't show anything?
Eat, drink, and be merry.
Okay. Somebody else asks, is the Atkins introduction phase diet dangerous for the ketosis it seeks to sustain?
I think so. Ketosis is not normal. Ketosis means your cells are starving. It means your body is starving. So why would anybody want to do that?
So the ketone diet that is popular, that's similar to Atkins, is that a healthy diet for anybody, or?
Well, it's always abnormal to have ketones in your blood, period. If you want to make your blood abnormal with ketones, go ahead. It's worse in diabetics because they've got fragile capillaries. So they're more prone to injury from intracellular. Remember, we've got to think about the inside of the cell, the little furnace. So you have blood sugar of 300, but inside the cell it's 50. And how do you know it's 50? Bingo, ketones in the blood, So that's how you tell. So that way you can you don't ignore the blood sugar, but you think of it as less important. Consistent blood sugars over 250 are fine, or 60, as the last caller said. Even 300. Now, 300 is a magic number for people. Doctors will start sweating if you tell them your blood sugar is 300. Okay. But it's not that bad. It's just another number. And you don't have to worry about it unless you've got positive serum ketones.
So where did all this misinformation come from? Why is it like this?
Well, it's an association. It's kind of like with our problem with opiates. People die. There's a lot of prescriptions. Therefore, the prescriptions cause people to die. Okay? In diabetes, people who are real sick and in the hospital have high blood sugars, which they do during their comas. And people with high blood sugars do have more complications. So therefore, the sugar's causing the complications. In fact, people with a lot of complications have more serious diabetes. And with injury to the pancreas, along with injury to your eyes and your kidneys, it doesn't make enough insulin, so up goes the blood sugar.
Speaking about your pancreas, somebody that I know that has pancreatitis disease, they do a certain surgery when it gets really bad. I forget the name of the surgery, but why, if they get that surgery, why do they often become diabetic at that point?
Well, it's funny about the little cells are called islets, SLET, because they look like islands. So sitting on top of your pancreas, picture you've just sprinkled salt on your pancreas. And each one of those is a little nest of cells called beta cells that make the insulin. And it's just riding along. The two are actually not related. The pancreas just provides a little platform for the little cells that make the insulin. Now, if you're going to rough up your pancreas and it becomes sick, you're going to kill off the little islets as well. So if you get a massive infection of your pancreas, the infection is going to affect the little salt grains of the islet cells that are making insulin. Even though the two are not connected, the inflammation of the pancreas also injures the cells. So that's kind of what we call secondary diabetes. It's not the primary kind that we think of every day.
We have another caller, a caller from area code 561. What is your name and what's your question for Dr. Kline?
Hi, my name is William, and I had a question.
Oh, could you speak up a little bit?
Hi, can you hear me now?
You're still a little low.
Hello, can you hear me now?
That's much better.
Thank you.
Okay. Hi, my name is William, and I had a question for Dr. Kline.
Shoot.
So my question is, I'm a practicing pharmacist here, and during pharmacy school they teach us a lot about diabetes, and I was listening to your podcast a few months ago. I think you did on diabetes, and I was just kind of shocked about the stuff you were talking about. So I was wondering if because I know you put out a resource about like the pathology of diabetes. I forgot the name of the author, but I was trying to look it up so I can just look into it more myself and understand it more. I was wondering if you could if you had the name of that book, the author.
The book was written in 1965 by 3 Boston pathologists called The Pathology of Diabetes Mellitus. And the lead author was a guy named Warren, W-A-R-R-E-N. His first name was Shields, like Army Shield, Shields Warren. And this was the first book published on the pathology of diabetes. What does it look like under the microscope? It's a lot more than just blood sugar. There's stuff under the microscope, And the book is hard to get, but you can get it through interlibrary loan because nobody bought it. I guess it didn't sound really interesting, Wait a minute, isn't it the blood sugar? What is this pathology stuff? That's bunk, so nobody bought it. And I think I mentioned last time I was able to get a copy from London, and I have it in my collection now, and it was rather expensive, but worth having, and most libraries can dig it up for you through interlibrary loan librarians. And it starts to give you an example. These are pathologists. These are people that observe things. They're not drawing a lot of conclusions. Sometimes as I'm reading it, I'm thinking, please make a conclusion, and they won't. There's problems with the basement membrane, which is the little guardian that allows things in and out of the cell. And if you're looking into it, you want to look up pericytes, Pericytes. I currently think that's the key pathological problem in diabetes. And it wasn't discussed too much back in the 60s because they didn't have electron microscopes and they didn't really see it. Picture a large plastic tube, and there's a dog laying on the top of it. And the dog reaches its arms and his feet around, and it holds the tube together. If you knock off the dog, the tube's default position is open. Now, blood vessels need to open when you have inflammation. You get a little splinter in your foot and it all turns red and swells. Well, that's because your capillaries are opening. Well, the little pericytes, or the little dogs, pull it open and then close it when it's no longer needed. If you kill off the pericytes, it lays there open all the time. And if you look at the pathology of diabetes, it's all about swelling. Your little nephrons inside your kidney, it's like scooping out a watermelon, with a baller. And so you put little cells in there. There's no place. If it swells, it just kills the cells. Same thing in the pancreas. In the back of the eye, there's no little scooped out areas, but the tissue is real thin to allow the light to go through. So you got this real thin tissue, a little bit of swelling, a little bit of capillaries opening up, and you got problems. So it's really the little dogs sitting on top of the tubes, the little pericytes, that get knocked off. And there's thickening of the basement membrane. There's a whole bunch of literature that goes back into the 70s about thickening of the basement membrane, and they got into fights over it. because when people started to get close to a pathological definition of diabetes, the the glucose control people started to become upset because they didn't want to hear this. This was an inconvenient truth. And so even the pathologists battled back and forth. The pathologists from Boston, battled back and forth like a bunch of little kids, like, that's not true, with these terrible, terrible arguments, like, well, I just don't think that's true. That's bunk. But there's definitely something wrong. My definition of the pathology of diabetes, it's a capillopathy. In other words, it's a capillary disease, a capillopathy. And there's something wrong with the capillary. There are other capillopathies, but that's my current thinking about diabetes. So you can start with Shields Warren, and then, you can email me too, and, I can kind of point you to some other authors that really got into the electron microscopy of diabetes. And you know what? The main thing is it makes sense. It makes sense. Yeah. For example, you can see capillary damage underneath your fingernails in diabetes, but it doesn't amount to anything. It's only where the leakage is trapped. And the islets in the pancreas are little scooped out areas, the areas in the kidney are little scooped out areas, and you can just see it's not going to be able to tolerate any swelling. The first pathological description of diabetes was in 1906 or thereabouts at the Johns Hopkins. A young student looked under the microscope and made this astounding observation. He was looking at the little scooped out areas of the islet cells making insulin in the pancreas, and he said, it looks like the swelling is outside of the capillary. There it is. The capillary is leaking. And so the fluid is outside the capillary. And it's just phenomenal that he just looked through the microscope and saw that. So.
Gotcha. Okay. Well, thank you very much for answering that. I appreciate it. All right. And I don't want to take too much of your time, but I had one follow-up question as far as what your thoughts are on just gestational diabetes and how doctors say, you have a higher chance of getting type 2 after gestational. So you should, do the blood pricks and all that and get a glucometer and check your blood sugars and all that.
That's one area I'm not really an expert on. It's I've got a bunch of papers and I just haven't gone through them yet. So I gotta demur because I don't want to say anything, that I'm not sure of. So, but a very good question.
Okay. Thank you.
All right.
Thank you, William, for calling in. Something I wanted to know about with ketones as well. I don't know if you've heard about the supplement ketones that people are selling. It's kind of like I think it's like what is it, the type of marketing where, you kind of build multi-level marketing, I guess.
Pyramids.
Yeah. And they sell these supplements anyway. And they said that you could go through like a ketone flu. I tried it. I got very sick actually. And, I met, somebody that was a pharmacist at one point, and she said, Janelle, anybody with autoimmune issues, you don't want to do that. Do you know anything about this?
I've not heard anything about it, no. But basically, we just stay simple. Ketones are bad. They're not good for you in your body, and I don't know whether you're adding them, whether it gets through your digestive tract or what. But I'm kind of Mr. Ketone. I think they're bad, but they're good because they signal things that are going on inside your little furnaces.
Okay. We had a question on YouTube. Miss Harris asked, well, she said she got a cell therapy treatment and the doctor gave her 6 shots of vitamins prior and he hit her nerves and she's been crying for 2 days. How can she tell the doctor in a nice way that he messed up?
You call up the doctor and you say, I think that injection made me worse and I'm going to call my lawyer if you don't fix it. Or you can just call him up and say, doctor, I think you poked me wrong.
Exactly. Somebody else wanted to know if a patient was to admit that opiates can make them feel better, much more better than they deserve. How do they still go forward with the truth about the need for them from a chronic severe pain while admitting this?
Gee, that sounds like some Puritan lecture, at church. Don't feel too good. Don't celebrate Christmas. And if you get pain relief and you feel great from it, oh, I don't know, that's kind of sinful. It depends on how you feel. I mean, pain relief is a wonderful thing, you just feel like you're floating. But if you're going on a magic carpet ride and you're shooting off to the moon, that's a different thing. That's the reaction that people get when they have type 2 opiate addiction. So if it's just making you feel good and relaxed, and you're not seeking more of it, you're okay. If it makes you feel so good, you got to go and find more of it, intense seeking, we call it, then you've got addiction. And you need to see an addiction doctor. There are real addiction doctors, hard to find, that are experts on addiction. So it depends on how good you feel. You feel a little bit good, go with it.
Okay. What do the role of antihistamines play in pain and antihistamines play in pain management?
Yeah, that's a very good question. There are some diseases like complex regional pain disease in which whenever you see something turning red, like all of a sudden it's turning red and it hurts at the same time, that means that your cells are releasing histamine. Histamine is a drug your body makes, and it's used in inflammation. It's a good thing, as Martha Stewart would say. But if it's out of control, if you get a bee sting and it turns red and it stings, part of that is histamine release. It's the histamines that are causing it. Theoretically, you should be able to make a bee sting feel better if you quick swallow a few antihistamines. But it is part of certain pain, and whether or not it's part of all pain is a very good question. I don't have an answer to that, but it's certainly part of it with the regional pain diseases when the sympathetic nervous system gets out of hand and all of a sudden your hand swells and turns red. That's histamines being released. And it thinks it's trying to guard you from a cut or a bunch of bee stings or a bunch of splinters by causing swelling and sealing off the area. You see, redness and swelling seals off the area, so the rest of your little white cells can get in there and munch up whatever it is and save your life. But if it's part of a painful disease and it's misbehaving, then you need to try to stop it. And so that's when we use antihistamines to try to stop it, and they can be pretty effective. So you see something that's red and painful, it's okay to try antihistamines.
What about inflammation, like what you were talking about with CRPS? I have CRPS and in my hands. Antihistamines, does that help with the swelling of them?
Yes. Because the histamine itself, the histamine is a drug. If I give you an injection of histamine, it'll immediately swell up and turn red because the histamine opens up the capillaries. Remember those little slits and the little pericytes holding the slit together? Well, the pericytes go, time to open up. And then all this stuff comes oozing out of the capillary, histamines, little white cells and all that kind of stuff. Because what guards us against disease is our ability to create inflammation. When we have influenza, we have a horrible cough, we feel terrible, your fever's up, because we are combating the alien by creating inflammation. So inflammation is generally good, but there's a lot of diseases when inflammation gets out of hand, out of control. And CRPS is one, really rheumatoid arthritis is one, where there's inflammation in the joints way out of proportion to what it should be. So anyway.
I know somebody that has a Hodgkin's lymphoma, and now they have continually, it seems like they go through periods of that they'll get kind of really pussy. They're like all over their back, their face, their arms, whatever. You could push down and pus will come out. Would a histamine help in that sense?
Probably not. That's more infection, need antibiotics, and and drainage, so probably not.
Okay. We had another question. What is clonidine, and how is it used when going through withdrawal from pain medication?
All right. Clonidine is a centrally acting medicine that's very good for withdrawal, and it works well. Having talked to an experienced nurse in addiction clinic, they say it's very effective. So yes, good drug for people when they're withdrawing, and it doesn't matter why you're withdrawing. The withdrawal from a heroin addiction is no different than the withdrawal from somebody who's been on opiates for more than 2 or 3 months. Both of you go through the same thing. That's a big myth. They think, oh, heroin addicts go through worse with. No, that's not true. The problem is that chronic pain patients go through the withdrawal, that chemical withdrawal that an addict would go through in addition to getting their pain back. So it's much worse. Heroin addicts do not have pain. They just have their withdrawal for 2 weeks, and then they got to deal with not having any medicine. But yeah, so with withdrawals, clonidine's a good drug for that.
I know that people in the past have asked if what other ways or what other little things that they could do when they are going through withdrawal that can help them kind of get through it a little bit easier.
The main thing is just to go slowly. It's hard because it's a biochemical interaction in your body. It's hard to stop it. But going slowly does seem to help. In spite of the fact that people quit smoking, it does not help. With smoking, it's better just to stop. But with opiates, it's better to kind of slide slowly. And clonidine really is the main drug that's used. Not too much else helps.
I know in the past when I've been titrated or taken off my pain medication, they use clonidine and Neurontin or gabapentin. And yeah, it seemed to help. I don't know.
Okay, I don't know the answer to that, so I'd have to kind of check into that.
Okay. Someone wanted to know, is the addiction response, the magic carpet ride, a result of activity at the mu receptors or somewhere else in a completely different system? And is it related to high or low efficient metabolism?
Definitely the mu receptor. Something's wrong with it. It was genetically put together incorrectly. So you've got a genetic malformation of the little receptors. And what they do is they overreact to a little bit of opiates. When people have an addiction triggered, the very first pill they take could just be a Vicodin or, a little bit of oxycodone. All of a sudden, the receptor acts like it's just gotten 1,000 times the normal. And it goes crazy. And you get a crazy, accelerated, increased, gigantic, wonderful, euphoric response. But the receptor is malformed. The receptor is not been made properly. And therefore, you are stuck with that because it's genetic. You're stuck with that malformed receptor forever. Pretty much like in diabetes. You're stuck with whatever's going on in the capillaries forever. There's some kind of error that occurs genetically. And diabetes is genetic too, by the way. So you just got to put up with it, and you can, but that's where it is, with the pathology of type 2 opiate addiction lies with the mu receptors.
Another question we have is, they wanted you to explain why 1 in 400 have the genetics set up to addict and 1 in 200 exposed may addict.
I didn't quite understand that. Basically, about 0.5%, or about 1 in 300 will have the genes for the abnormal mu receptor. And all of those people have the potential to become type 2 opiate addicts and be triggered with just 1 or 2 pills. But there's what we call in genetics variable penetrance, which means you can have a whole family of diabetics and you'll be born, you're not a diabetic. You can have a whole family of people carrying the bad genes for type 2 opiate addiction and you'll squeak through. Or you'll suddenly develop the addiction and nobody in the family has it. So it's not a perfect scenario, but it does occur in 0.5% of the population. And, that's not very much, but it's 4 people per 1,000. So if you got 100,000 people, then you've got 4,000 addicts. So that's a lot. 400 addicts, I'm sorry. So that's a lot in a town, 400 people, classified as dope fiends running around living behind dumpsters. And that's not true either. There's a lot of people that have type 2 mu receptor addiction that lead normal lives. They just have to get hold of enough opiates in order to keep their addiction in check, and that's difficult because if you try to go to a pharmacy, the police come to the pharmacy and arrest you. Oh my God, another doctor shopper. Yeah, well. It's a disease.
Yeah. Marcia from YouTube wants to know if she severs her relationship with her PM doctor, will it make it harder or impossible to find another doctor willing to take her on as a PT?
Yep. The problem is that you're labeled. See, you got this A on your forehead, and actually the story was an A around her neck. But so you got this A, addict, and yeah, you got to be cautious about severing. What you want to do is say to the doctor, give them some kind of reason that you're leaving. You live too far away or something, and you want to try to find somebody else. The problem is it's getting almost impossible to find people. I talked to people who have called like 30 doctors. Then I tell them to call up the Board of Registration in Medicine and the Medical Society. We can't help you. Well, that's real nice, because everybody's a dope fiend. That's why. We've got to really change this, and we've talked about this a lot. And, we want to put people out in public who have painful disease and people who have addiction, and show the citizens of the United States these are not dope fiends with horns. These are just regular people, and they've got these god-awful, painful diseases, and they've got this god-awful type 2 addiction.
Someone wanted to know, why haven't we heard from the Joint Commission on acceleration? Is that how you say it? On the opioid epidemic? Accreditation, sorry.
Accreditation. Yeah, the Joint Commission on accreditation, first of all, is not joint, and it's not a commission. It's a private group of people, because the United States government says if you run a hospital or a nursing home, you have to be accredited, and we want to be sure that you're doing things properly. And so my experience with them has been they're always following the problem. Soon as there's an opioid addiction, then they will come up with these standards. It's a big sales pitch. I don't think much of them. I don't think that hospitals really improve their standards with what I've seen, which is a bunch of phony paperwork things and books that you keep, instead of asking patients, gee, did you get good care here, and checking on the doctors, how many people died, after your surgery. Those are the things that should be done, but they don't do those, because what they want is people to pay for the accreditation and not take it away. The only time the Joint Commission takes accreditation away is after somebody else does it. Then they jump on. So whatever they say is not valid. They used to have this, they were on to pain. There should be this pain monitoring for all the patients. And then the opioid fanatics came in and said, oh my God, don't ask people about their pain. They'll just take pain medicine and become dope fiends. So they took it off. How sick is that?
Yeah. Ms. Harris from YouTube wanted to know, have we heard from the HHS on this topic other than them asking for comments from the public?
No, I haven't waded through the paper. You can't have an opioid summit without a 100-page paper, because if you write a 100-page paper, that makes it better. Pain medicine is pretty easy. It could be a 2-page book, Here's what it is like to be in pain, and here's the medicines that you can use to relieve it. And there's no other medicines that work, and all this other stuff, is not going to work. So you start off giving them pain medicine. If it doesn't work, you double it. If it doesn't work, you double it. 2 pages, So 100 pages. I started reading it, and it just had all this apologetic language in it, like we're really afraid to say anything. So, we'll have the multidisciplinary approach. to pain. Well, multidisciplinary. You write an order for some pain medicine and leave. So.
Someone else asked, who is forcing the tapering of benzos used for sleep and anxiety that is often accompanies symptoms such as fibromyalgia and Hashimoto's or intractable pain? And what can be done about it? This includes soma. I know they are calling it deadly, the deadly 3, but it wasn't deadly for eons.
Well, it's certainly deadly out in the opioid addiction community where people take whatever they want. But it's not deadly in the general population. I'm afraid that's just not true. The FDA says when you take these two together, be careful because you're combining two drugs with sedative properties, and therefore you can become over-sedated. Well, we're not idiots. If you're taking a pain medicine, I say, well, if you want to start your benzo, let's start real slow and see if you become sedated and sleepy. And if you do, we'll cut it back and we'll just give you less. If you don't become sedated, you're fine. You're not going to drop dead if you're not sedated first. So fear of addiction, phobia, rampant malpractice, denying people these wonderful drugs, for anxiety. I mean, they do work, I wish I took them. It's fear of addiction, phobia, and there is no justification. So doctors who cut you off can be held accountable. You have done me harm by forcefully taking away this medicine or using extortion and saying, well, you want your pain relief? Oh, you got to get rid of these benzodiazepines because we're all so scared of lawsuits and the police coming. Oh, wait a minute, you're the patient and you have anxiety? Well, that doesn't matter. We're afraid of the police coming, and that's what you need to know there, Missy. So sorry, no Valium for you. But you can have either one. What? I mean, good Lord, what's happened? This isn't the way it is around the world, by the way. There are real doctors in Spain and France and other countries and who don't do this because they know, okay, we're going to give these two drugs together and we're going to monitor, and if you're okay, we're going to continue with the drugs. So,
well, we're going to wrap up here. Did you have anything else that you wanted to add about the main topic that we talked about tonight, or anything else?
Well, you know what? If you have a glucometer, especially if you have an Abbott precision glucometer, you can order ketone strips online on Amazon for about $1 each. And you put the little strips in the same machine. So all Abbott precision glucometers can do both. And they're one of the few companies that it's not widespread. And get some little strips and check, when your blood sugar is real high or your blood sugar is real low, put in the ketone strip and see what you get. You can start monitoring your ketones. It's also a great way for you diabetics who know what ketoacidosis is, picking up the ketoacidosis early, especially in children. Some kid looks funny in the morning and you wonder, there's a ketoacidosis coming. Wham, you check the ketones and there it is. It's warning you. As a matter of fact, during ketoacidosis in pediatrics, they don't follow the blood sugar. They only follow the ketones. It tells you exactly what's going on inside your body, so that when you're giving insulin to treat a diabetic coma, you don't overshoot and give too much. You just follow the ketones. It's a great test and very underutilized. And now, with the price going from $5 to $1 a strip, I think everybody should get them, get a bag of them like, donuts. They're about the same price as a donut.
Okay. Well, a big thank you to our audience for taking some time out of your evening to join us here at the Doctor's Corner. Just a reminder, next Tuesday, we're going to have special guest Josh Bloom will be joining us. And then next Wednesday, on Conspiracies Against Wellness, guest Claudia Morandi from Don't Punish Pain Rally will be with us. Then the following Tuesday, January 29th, is the National Don't Punish Pain Rally. Dr. Kline and I will be at the Raleigh, North Carolina rally, live on the Doctor's Corner. Make sure to stop by and say hello. I'm Janelle Elgway with Dr. Kline, signing off until next Tuesday. Have a good night, everyone.
Good night. Good night.
This has been The Doctor's Corner with Dr. Kline and Janelle Elgway. Copyright 2018. All rights reserved.